Well, good afternoon, ladies and gentlemen, and a very warm welcome from a sweltering Cape Town. It's 34 degrees Celsius outside, and I'm hoping we have some coolth in the few days ahead. It gives me great pleasure this afternoon to introduce our speaker, which is Professor Stephen Jeffrey. He certainly doesn't need any introduction and won't get one from me, and he's speaking about shared decision-making in urogynecology. There is no better person than Professor Steve Jeffrey. I rate him as one of the 10 best urogynecologists in Cape Town. And he's speaking then about shared decision-making in urogynecology. The talk today is sponsored by Vertice, and we're going to have a few words by Ruby Franken at the beginning. She's the Business Management Officer and CEO of Vertice. And I'd like to thank her once again then for sponsoring the webinar this afternoon. She's going to give us a brief video at the end to play out with. Next week, ladies and gentlemen, we have Dr. Clayton Hall. He's a lawyer, and he's speaking about medical malpractice and the medico-legal implications of medico-legal problems. And the sponsor there, of course, would be NatMed. I had a message over here from Karen who says, please encourage the audience to join the newsletter if you've not already done so by checking in the chat box in Zoom. I will load the link to join in there. And to anyone that has already subscribed to the newsletter, please take 5 minutes and complete the survey so we can make 2024 webinars much better. Now, this is season 5, episode 28 of the webinars. So I'd like to thank those that have been with us since season 1. And now I call upon Ruby Franken, the CEO of Vertice, to give a very brief introduction. And thank you once again for the sponsorship. Ruby.
Hi, good evening. I wish I was the CEO. I am, however, the business development representative, but I am very honored to be here and give you guys a brief overview of the company for those who are not familiar with the company as yet. So Vertice is relatively new, established in 2018, primarily through acquisitions of several known entities to us, such as Legacy Medical and EVMS in the urology space. So although the company is new, it has a very established history in the market. We are a little bit unique in our position in terms of very actively trying to occupy the space where healthcare and technology converges. I think we recognize the constraints in our market, and we actively look for opportunities where healthcare can help us unlock some of the barriers in terms of access, financing, and service to the greater public. We have a really broad overview of products. Obviously, of concern this evening is the women's health, which sits in our surgery division, and the urology portfolio that we have. But we've got about 22 specialist divisions with a very strong foundation of technology that underlies the business. Some of the distinctive elements is that we are the only South African distributor that has certified health information software solutions. So we have a strong Microsoft partnership in terms of this emerging landscape around patient data and correlating data with outcomes. We have some distinctive payment solutions that we've developed for healthcare expenses in the South African market. I think we've got nuanced constraints in terms of patient access. But this is also an exciting solution for healthcare specialists in terms of positioning around some of the constraints that we have in the private sector. We have edtech solutions that span a really vast portfolio from online courses, webinars, various partnerships with higher learning institutions that are accredited, remote proctoring solutions, which we've recently introduced to the market, and of course, surgical simulation platforms. We then have a mobile health division that can deliver services from radiology and communicable disease screening, and very soon surgical services into the rural areas in partnership with global funders, as well as the provincial departments of health. And again, one of our distinctive capabilities is our ability to introduce digital health services into specialist markets, most notably our ECG platforms. We aim to be with you all the way from the screening of your patient throughout the care continuum, right down to the evidence-based outcomes. And we have solutions all along the patient care continuum that you can just reach out to any of your representatives for if any of these solutions are something that appeals to you. We're primarily in the South African market, but we have distribution and a footprint into the African markets. And this is something that we're looking to strengthen in the near future, hopefully in partnership with our specialists in the South African market. And that, in a nutshell, is an overview of Vertice.
Thank you very much indeed, Ruby. If I can just ask you one question, if I may, just
Absolutely.
before you say goodbye. You say you have a distribution. What products do you distribute? Are these products? Could you give us an idea of what sort of products these are?
In the urogynaecology space.
Yes, that's right. Legacy used to be laparoscopy, things like ports, instruments, and so forth. Do you still do that?
It's still the same ones. We have some energy devices that we've brought into the portfolio as well, which are quite unique. We have some Botox needles in the urology space. So I think there's quite a nice hybrid between the urology and the gynecology spaces that we're trying to bolster. And I think we've got a very strong pipeline that we would be happy to detail you on early in the new year.
Okay, I'd like a representative to call on me because we've got products that need distributors. Thanks very much indeed, Ruby. And now, Steve, are you still with us?
Yeah, absolutely.
All right. Shared decision-making in urogynecology, Professor Steve Jeffrey.
Well, thanks so much, Pete, for the unkind introduction. But thanks so much. Thanks to Vertice and Ruby for the account sponsorship. And they absolutely make some great ports and some great laparoscopic equipment. And really be worth looking at some of the equipment that they are able to provide you with. But yeah, we're talking about this whole issue of shared decision making. And in fact, what we will talk about tonight doesn't only specifically relate to urogynecology, but it relates to a lot of how we communicate with patients. And as you can see from this WhatsApp I got from a patient last year, I'm experiencing constant drip of urine. Is it likely that this problem will resolve itself? She knew that I was traveling, and I was in fact communicating with this patient on WhatsApp, which is something that unfortunately we are finding ourselves doing more and more these days. Another patient, good morning, update on Michelle. This is from her husband, and you can actually see just a range of questions about her traveling back to Joburg after having an operation with me, and really dealing with an outcome which was not really perfect after one of the surgeries that I'd done. And so as we embark on surgery and the outcomes of the types of procedures that we do in urogynecology, we do need to remember that we are often entering a minefield, and we do need to be careful of how we approach these patients. Now, a lot of the patients are quite straightforward. I mean, as just a typical history that you might find, a 46-year-old patient presenting with severe urinary incontinence, no urgency or nocturia, you can't run, laugh, or cough without leaking. And when I examined her, significant stress incontinence and no prolapse. And in fact, up until very recently, this was actually quite an easy patient to manage. I'll just get my slides to move on to the next one. And yeah, you can actually see up until maybe 5 or 6 years ago, you could either go and do a retropubic TVT, or you could go and do a transobturator tape. And in fact, most of these patients would do quite well with that. Unfortunately, things have changed a lot over the last few years due to this massive issue that hit the South African shores not too long ago, where Johnson & Johnson was hit with a class action relating to pelvic floor meshes. And unfortunately, this did bring into scrutiny amongst patients, specifically on social media and in the news, internet programs. There was a terrible carte blanche program where they delved very deeply into this for the very one-sided, and I'll say that without any hesitation, one-sided, reporting on this issue related to mesh and the Johnson & Johnson and Coloplast class action. And so this has made the issues very difficult for us to deal with. In fact, this wasn't a new thing, and it just shows you how ridiculous the whole issue was, in that this mesh issue and its political involvement started with the Scottish Parliament. And you can see this guy called Alex Neil, who was a Scottish parliamentarian, I think it was the Health Ministry, Health Secretary. And he brought this, some of the mesh-related complications up into Parliament I think it was in 2014. So this issue in South Africa is 9 years later, and it doesn't really make sense that it came up so late. But just really trying to highlight the fact that the social media issues related to what we're talking about in urogynecology are significant, and it certainly impacts on how we talk to patients and how we actually make decisions with our patients. And it's a classic example of what you would really try and need to negotiate, and how you would discuss your plan of action with a patient when you're seeing them in preparation for their surgery. And really just to highlight some of the major issues, this was Dr. Carl Hennigan, actually. I just want to go back to this article, who was a professor of evidence-based medicine, who at the bottom there, you can actually see that he says that this mesh-related scandal is the same as the thalidomide scandal, which I certainly don't agree with. Thalidomide was a product that was used in Pete's days. You remember that quite clearly, I'm sure, Pete?
Steve, can you hear me? Yeah. In
Yeah.
fact, it was a wonderful anti-nausea drug,
Yes.
and it's now used sometimes in oncology as an anti-nausea agent, and it's wonderful unless you happen to be pregnant at the time.
Yeah. So unfortunately, this guy's really thrown the whole thing into the same sort of category, which I don't actually agree with. If you look at the Cochrane review, which is the evidence base, it's the medical literature, it's what we turn to for a lot of the condensation of the medical research. You see a different picture. Midurethral slings are being the most extensively researched metasurgical treatment for stress incontinence. They have a good safety profile, irrespective of the routes traversed. They're highly effective in the short and medium term, and the accruing evidence demonstrates the effectiveness in the long term. And there you go, completely different perspective from what we actually seeing in some of the social media posts about TVTs. This is a Yugo position statement, and looking at really the global position is to support the use of midurethral slings. Again, very different to what we're seeing in social media. And this is based on 5-year data. And in fact, there's now 17-year data on the retropubic TVT. And this is good data. These patients were dry 90% of the cases in this actual study, which was actually published long ago. So we have good evidence to suggest that these are actually procedures that are still safe and can and should be done in patients.
Steve, can you just go back to that Falconer article, the previous slide?
Yes.
Okay, that's Chris Falconer. He came out here in 1997, and he was the first person to do the retropubic TVTs. In that 17 years follow-up, what complications occurred that have been referenced in the latest Scottish hype? In other words, after 17 years, there would have been complications had they existed. Mark Slack, when he was here last week, did say that you can't look at a new device before 5 years have elapsed if you want a true reflection of whether or not it does have complications. What did Chris Falconer and them find 17 years after the first TVTs were inserted? Were there any complications worth noting?
The only significant complications were some patients with voiding dysfunction and mesh exposure. But those appeared in the early phases, and no long-term sequelae were noted at all. So there was no patient developed. If you look at some of the websites like Sling the Mesh, there's a Facebook group called Sling the Mesh, and there's also Instagram and Twitter, etc. But they talk about IBS, they talk about patients developing rheumatoid arthritis. They have issues related to depression and anxiety, all due to the look. Pain, we know, is common, and it makes sense. If you put a foreign body into a patient and it's incorrectly inserted, or if there's an unfortunate tightening in the wrong place, you will get pain. But they're taking the complications related to some of the slings to a completely different level, where they're blaming things like irritable bowel syndrome on the sling, and there's a whole range of complications that they're blaming on the slings, which I actually don't really agree with, and it's not something that we should really entertain. And it really comes down to the fact of how do we counsel our patients, and how do we treat our patients in the context of everything that has been said on the social media relating to these specific devices.
Thank you.
So this then brings us to the fact that there are indeed complications. This is a patient who's having a TVT, and you can actually see the tape was the inserter was placed into the bladder. This is a terrible complication that occurred at Urogynaecology, where the tape was placed into the bladder and not noticed. And 2 days later, and I have shown this picture on numerous occasions at different workshops, but here you can actually see this patient, because of this missed tape, the patient ended up developing severe necrotizing fasciitis. Ended up spending a Saturday afternoon with the surgeons resecting a large piece of abdominal wall due to this necrotizing fasciitis from this missed tape. This is a patient who got an abscess in a groin from a TVT. This is a more common and a complication that we see quite regularly. It's well, not regularly, but we do see. And this is an exposure. You can actually see how this tape is now poking through the vaginal skin and developing, and in fact, I saw a patient today who's complaining about a husband feeling this sling. So these are real complications that do happen, but in fact, this one is quite easy to fix. You just go in and remove that little bit of exposed mesh. This is a quite a significant complication of a sling that was placed through the urethra. And this patient required a formal excision of that tape and later required a laparoscopic birch copper suspension to address that issue. And here's another tape that you can actually see in the bladder. Hematoma as well. So you can actually see there are some significant complications, which is then means that we need to start talking to patients about alternatives, and patients come with varying degrees of knowledge about alternatives and about what you might want to offer them. And so I think it is important to understand that there are alternatives. The Bulkamid is a very nice option, and this involves basically taking a little needle and through a very small scope, I'm injecting this agent into the bladder neck. It's polyacrylamide gel, very benign, inert, and as you can see in this video, it involves injecting this bladder neck. Normally go about 1.5 centimeters away from the bladder neck into the urethra, and as you inject, you then create these 4 blebs around the bladder neck to then occlude the opening and thereby creating a continence. Great procedure, almost no complications, but it doesn't work as well as the TVT with continence rates of about 60%.
So it's considerably worse than the TVT in the maintenance and attainment of stress incontinence. Why would you use it then if it doesn't work, Steve?
Well, again, it comes down to the patient's risk aversion and the quicker recovery, and just really the fact that it has much lower risk of complications.
So you would use it. There is a niche indication for Bulkamid, and it's an otherwise very safe product.
I did one yesterday. It just doesn't create as much occlusion, doesn't have the risk of all the foreign body things that you might have from a TVT. And although I'm quite negative about it, in good hands, it actually is very successful. And Kathy Lepley from Meducat, who is the marketing group for this device, they're finding some people well, specifically, I know in Joburg, they're getting some very good results. So it is as you can see, it does require a little bit of a knack to do it, and the learning curve, etc. But for me, I do just prefer to do something that I know is going to work very well, like TVT. So that's the one thing. And then the other option is this fascial sling, where you need to go in and take out a piece of fascia, 1 centimeter wide, about 8 centimeters long. You put it on the end of these strings, and then you basically create this sling, and you're basically doing a TVT from the patient's own tissues. And you can actually see how it goes in, but you do need to make quite a big cut on the abdomen to get this thing out, and then do this sort of a very elaborate new fascial sling, where you then tie these sutures across the midline, and that's how you create continence in these patients.
Do you ever do that operation? You go back, Steve. Do you ever do that?
Yeah,
sling using
maybe 2 or 3 a year. Again, for the patient who might have had a previously complicated sling, or maybe had some I've had a patient this year who had a previous mesh erosion of a sling to the urethra, and then followed by bulking agents, and you're dealing with a very complicated situation, and you don't want to go put another foreign body in, and that's when you could think about doing it. But I don't really like it, Pete, because it's you've got this abdominal incision, you're working from the bottom, and the top is the potential for infection. You've got an abdominal wound, and the only nice thing about it is you can actually make it really tight, and if you do need to loosen it, you can. But as I said, I don't really like this procedure.
We used to do lots of them 20 years ago. It used to be called, this is before the TVT, it was called the David Lee sling. The big problem there, apart from, as you've mentioned, the technical problems, is that very large abdominal harvesting incision is very painful, because often any incision greater than 15 centimeters in length at that spot damages the ilioinguinal nerve, and the patients then go from a stress incontinence problem to a ilioinguinal nerve pain that lasts for years onwards. So you're just causing one set of complications on top of another set.
Yeah, and then it brings to the, thanks, Pete. I agree, and it's yeah, I don't really like doing that operation. This is the third option. It's another option that I saw for the first time when I was a first year working with Dr. De Jong as a registrar. An open birch carpal suspension. We now do this laparoscopically, and for the registrars and for those who're not really aware of this operation, you go into the retropubic space, find the bladder neck really, and basically put 2 or 3 sutures into the bladder neck and then attach it onto the iliopectineal ligament along the pelvic side wall over here. And the success rate of this is actually really good. It's about maybe 80 to 90% and almost as good as a retropubic TVT. So this is a good alternative in the patients who really don't want any mesh involved. And you speak to the people from the UK, this operation has been revived quite significantly. And then there are some other options which aren't surgical at all. The laser, fractionated intravaginal laser, works in very few patients, but is an option, and some of the data does support its use. And then you can try this M-Cellar chair, which is available in some places in Cape Town and the rest of the country. And yeah, you can actually see it basically rates electromagnetic stimulation of the pelvic floor. And patients require 6 sessions, and I think they're charging anything between 6,000 and 8,000 rand for the course of treatment.
But does it work, Steve? Would you say it's
I'm not the right person to ask, Pete. I had one as a demo model in my office for about 3 months, and the patients that I did have were it wasn't as effective as I was hoping. But in fact, I think you should talk to the people who do a lot of it, and maybe it probably comes down to patient selection. And I think in the severe types of incontinence that I would see, it's probably not the right thing, but certainly does work in some patients. Otherwise, I'm sure that my colleagues wouldn't actually buy this machine, which costs about R1 million.
Ooh.
And yeah, so, but it is useful for other things. And so, yeah, I don't want to be too critical about it because I don't actually have a lot of experience with it. But I know there are colleagues of ours who have it, and it actually works in some patients. But the nice thing about it, you sit in it with your clothes on, you walk in, you walk out, 20 minutes and you're done. But, you know, the question is maybe how good is this compared to physiotherapy? So maybe you'd rather spend that money on physiotherapy. But I'd be very happy to hear some other opinions about that.
What does it feel like when you sit on that? Does it just cause contraction of your pelvic floor, or does it vibrate?
Yeah, you use your pelvic floor sort of squeezes. Yeah. So yeah, so that then brings into question what do we do in these patients, and what do you offer your patient when she comes to you complaining of stress incontinence? I mean, do you still offer them a sling? Do you go through the whole treatment course? To be honest, I still think this is the best option, and I try to coax my patients in the direction of really going for something that I know that works, something that is covered by the medical aids, something that will indeed give them the best shot at being dry.
Now, Steve,
yeah,
just go back one more. If you're doing the sling, the retropubic sling, I know that's your go-to operation. Has the class action against J&J Ethicon in South Africa included or encompassed the use of that Proline mesh as used in that sling?
Yeah, they are including a range of products, but I certainly think that the TVT is one of them.
Wow.
And yeah, and yeah, so it's a tricky one, but I've I've told them, the guys that are defending them, that I think it's in the best interest to make sure at least that we inform our patients and inform the public appropriately about the safety of this device, and that's one thing that I feel quite strongly about. But again, I mean, you can see you've got this diverse range of opinion, and including some of our medical colleagues that are speaking out against these things. But there we go. we do see complications, and this is just another patient of mine who, is complaining of some urinary leakage, and again asking me questions. In the UK, we can look to another medical community or society where they are, having to deal with this issue and how they take patients through the counselling process. If you want to have a TVT in England, you are going to have to jump through quite a few hoops, including being discussed at a multidisciplinary MDT. You will then have your moment with this very detailed decision-making aid, and I'll actually just run through what it actually looks like. So it's not a bad little document, and it talks about this National Institute of Clinical Excellence, which advises treatment in the UK, and they do talk about lifestyle changes, pelvic floor training, and surgery. Trying to get patients to understand risk is also quite a challenge sometimes, and yeah, you can see they've got some nice little graphs and little big pictures of how to understand risks. But really just the pointer is taking time to take your patients through the options, and then you can see they go through everything. They go through colp suspension, rectus fascial sling, retropubic sling, advantages and disadvantages, bulking agents, and yeah, you got to tick what you want to have, what's important to you, running through the different complications. And so my point really, and this is actually what I'd like to say, is that I think what this whole drama has done for us is that it's actually added a lot of time onto what we do, and also just taking a step back before you actually go ahead and book a patient for a procedure. So my approach is really making sure that you have the right diagnosis, because that's obviously going to create a big issue for you if it does come down to a medical legal problem. Really make sure that the indication is correct. And then I think the other basic principle of shared decision making in any part of medicine is really trying to understand where the patient is in terms of their knowledge base before you go ahead and start prescriptively explaining to them what you think they should have. So I think it's very important, take a step back, ask the patient what they know, try and understand what the patient wants and where they are, and then you can actually start to counsel the patient properly. You might find that the patient doesn't have any awareness of this issue. Then you can say, okay, well, let me explain to you what you might find, because remember, the patient might indeed go and Google anything later. So you want to give them a good base for which to go. I've had patients who called me the night before surgery where they've got a daughter in England who suddenly says, what are you having? I'm having a TVT. No, you're crazy. That's a very dangerous device. Suddenly they're sent into a tailspin because they're having something that they didn't know was controversially, on the radar of places in the UK. So you do need to then go back. But I do have a picture of a ProLift available for every consultation. I show them this. I say, this is basically why we ended up in this problem. This is a big piece of mesh that was pulled off the market in 2011. We don't have it anymore, and that's why they're being sued. And I show them the little arms going through there. I said, this is completely different to what we have. And then I show them the picture of the TVT, and I say, this one is actually completely different and it works really well. I normally write down for them. I explain to them that they can have laser. I say they can try the chair, and they can have pelvic floor exercises. All of these are good options, and these are all very, very non-invasive and, very safe. But I say that ultimately you might end up with an operation, and I explain to them the success rates of the TVT, but I very clearly explain to them there are risks. I talk to them about bulking. I don't discuss with them the option of a fascial sling or birch carpet suspension, because I actually, to be honest, don't really believe that it is a realistically good option in a lot of these patients. I don't know what you think, Pete. Do you think we should be embarking on this extensive range of options with patients when you in your mind wouldn't really offer it to someone close to you, your wife or your mother? I don't know, Pete, what do you think? Do you think we should be going down that whole route with patients?
Well, let's start with the birch. If a woman has stress incontinence and also requires hysterectomy, for example, then you might have a birch in play. I know that some of our colleagues do a Birch operation at the same time as, for example, hysterectomy or perhaps prolapse procedures. However, my preferred opinion would be to do your standalone procedure, say hysterectomy or prolapse procedure, and then still, in addition to that, do the sling. Not only would it be quicker, but I think it would be more efficacious. So the Birch has a very, very limited role, and those only in the hands of certain surgeons. So I would say, now I know you feel the same way as I do on that, Steve. We wouldn't do a Birch if you're doing, say, a sacrocolpopexy or something. You would do your sacrocolpopexy, then come and do maybe a mini sling. In terms of the fascial sling, having done many in the past, I feel that it's such an invasive operation that has so many side effects and complications. I feel that it's a very, very niche procedure nowadays in 2024, and I wouldn't recommend it as a first line or even second line operation. That's my feeling, Steve.
No, good. No, great. I don't like the fascial sling at all, but there we go. And good. Let's look at yeah. So I mean, this whole intersection between the consenting process and the shared decision-making process involves explaining efficacy, informing about the patient's complications, and explaining the alternatives, and documenting this as much as you can. And Pete, this is very much, you know, I think down your alley. I know you've actually, you know, been doing some medical legal work this week in court. I mean,
Spent the whole week in court, Stephen.
Yeah,
that's why I'm
yeah.
drinking whiskey.
I'd love your opinion on how do you see the consent form, the documentation process, and the whole you know, process of getting the patient to surgery, and how that is actually viewed in a medical legal sense. And what are your opinions on us actually really trying to stay out of
Yes,
court?
indeed. It's a very apposite question. And we do have Clayton from NatMed, I mean. Clayton of NatMed is going to be giving a talk next week and the following week. We sign him up for 2 weeks. So he, being a lawyer, would be eminently suitably qualified to address those questions. So if you wouldn't mind hanging on for a week or two, we would be addressing those at some length from a legal perspective.
Yeah. But there we go. So, I mean, really just getting that intersection correct, and the consent form, just because it's on the consent form doesn't mean you're going to be okay. But you need to have some sort of documentation process of how you've explained and how you counsel the patient.
Absolutely. Remember that the consent form does not indemnify you to medical legal malpractice. You're still liable, and you can't sign your waiver the patient's rights just because they've signed a consent form.
Yeah. There is a new thing, a new way of looking at this. Previously, we were judged on the Boland principle, which is really where you were compared to your sort of reasonable colleague, and you know, if everyone, if some people would have done what you'd done, then you would have been fine. And you were, you know, liable to discuss the clinically significant risks, and the risks that you were, you know, supposed to be explained to patients was anything that was important that you felt was relevant and quite common. But the Montgomery ruling of 2015 changed this a lot in the UK, and this was basically a woman called Mrs. Montgomery who's wasn't offered a C-section, and her son developed cerebral palsy. And the main shift in the way that medical legal cases are now seen was the fact that this woman wasn't actually given the option of a C-section. So it was just really how she was counseled and the options given to her. And this did have was a sort of a material shift in the way that medical legal things were seen in the UK. And so I think it's really important, as I've said already, try and understand the patient's knowledge before you start. Go through decision aids, use pictures, put a lot of these things into my notes so that if it did come to a, you know, a court or a lawyer wanting to see what was done, I think it is quite nice. I've done some medical legal work myself, and it is quite good to see how the doctor or the sort of plaintiff or the defendant was actually, you know, counseling his patients or her patients and what they were actually done to you know, keep the patients informed. And I think it's important to try and really understand if the patient has Googled anything or read anything about the issue at that point.
Steve,
yes.
Steve, can you just go back to the Montgomery? We
Yes.
have Anonymous, who I recognize as Habib M. Habib from Nairobi. He says, can you just go there? He just wants to take a photograph, he asks, a screenshot, if you will, because he didn't quite get to the bottom. So basically, this was a short woman with a poor pelvic outlet. She was diabetic. The baby was 5 kgs. It got shoulder dystocia, was delivered vaginally with disastrous results. She wasn't offered a cesarean section, which the court felt was the right option for delivery, and the Lanarkshire Health Board was found guilty, and a large sum was settled on the unfortunate Mrs. Montgomery and her child. Okay, I think that's enough.
Yeah,
and I
so you
think
got it. So really, the point here was just, and it comes down to, this ties in very clearly to what we're talking tonight. It's really just, you know, I mean, it would, I suppose the Urogynaecology or the stress incontinence equivalent would be to say, well, let's see a patient, you see her, she's got stress incontinence, and you say, okay, I'm booking you for a TVT next Tuesday. And off she goes, and she has a TVT, and she has a terrible complication. You perforate the bladder, and she gets the recurrent UTIs with a mesh in the bladder. Then she comes back a few years later, and she wants to sue you. And then they say, well, did you discuss the option of physiotherapy with her? Or did you say to her she can have a laser or an Emsella chair? And you say no. And they say, well, maybe she would have gone for that because she didn't want to have the risk of a big complication. So, I mean, that's the sort of equivalent here that we're talking about tonight. And I suppose it covers all the things. It covers the hysterectomy. It might cover TL, you know, all the things that we do. It might even come down to the HRT that we prescribe our patients. You know, a patient might come back with breast cancer after a few years of your HRT that you've given her, and she might then say to you, well, you didn't discuss the option of a fan with me or something like that. You know what I mean? Just really being a bit ridiculous, but that's the sort of thing. I don't know if you wanted to add anything to that, Pete.
No, I think you've covered it beautifully.
Okay, but I mean, then the other issue that I see a lot of is prolapse. Very tricky patient like this, big BMI, smoker, ischemic heart disease. She's already had a sacrospinous fixation. There she presents with a prolapse. What are surgical options in this patient? Very difficult. I mean, do we go and offer her a sacrospinous fixation, a fascial sling? I mean, we know that a mesh is actually probably necessary in this patient, but how do you bring a whole mesh into the equation when you've you know, have these big issues that patients are aware of? And yeah, here's my patient to WhatsApp me 2021, operated on me in June 2020, fixed my prolapse, had no issues for until 2 days ago, and now she's back with another prolapse and still wanting to come back to me for some reason, despite the fact that she's got a recurrence. And, you know, if you are doing any patients with urogynaecology, this is some data from Kim Kenton, old study, but 42% of patients presenting with new symptoms after pelvic floor reconstructive surgery. Incontinence, urgency, frequency, voiding dysfunction, difficult defecation. It's not the prolapse you're worried about, it's the other issues that might develop after your prolapse surgery. So it's the complications that scare us. This is a ureteric kink. These are all from my own patients. This is a bladder injury that you saw during surgery. And those who had the live surgery last week, we had another case of a bladder injury. This is a hematoma after sacrocarpopexy. Oh no, I think this is a vaginal, which is actually got off the internet. And this is another patient who developed a exposure of vaginal mesh following a posterior prolift. Previous care patient, you recognize the linen, sacrospinous fixation the previous day, and when I got to the ward, she was experiencing significant pain in her buttock from the impingement of a sacrospinous fixation that pinched the epidendral nerve. Let's get back to our patient. So what are our surgical options here? Well, you need to just go back to your basics and see what options you would still have. And you could go and do another sacrospinous fixation. There are some pelvic meshes still available in South Africa, but to be honest with you, I don't do any of them simply because of the dramas relating to the pelvic floor meshes and the new class action. Colpoclesis isn't an option for this young patient, but it is something that you possibly even need to mention to patients. And I have done a colpoclesis in quite a young patient, and it maybe is something that you need to talk to about patients too. But we all know that a sacrocolpopexy is probably the best option for this patient. But you do then need to say to them, I'm going to be using mesh. And that is then a new discussion that you need to have with the patients. This is a balancing act. You're balancing the risks of sacrocolpopexy versus a vaginal native tissue surgery. And you also then need to bring in a whole lot of new decisions in these patients. Do you do hysterectomy? If she's not at a hysterectomy, I often do hysterectomy at the time of prolapse surgery because I believe it improves my outcomes, especially of sacrocolpopexy. How do you do a sacrocolpopexy without mesh? You can't. You have to then start thinking about a uterosacral ligament suspension. What about the option of a colpoclesis? We already discussed that. And then what about adding a sling? Does she have leakage? If she doesn't have leakage, she might indeed have some leakage after you've done your sacrocolpopexy or prolapse surgery. And then again, you know, what do you want to do? Do you want to add a sling at the same time? Because you know she might develop stress incontinence after your procedure. And so, yeah, and then obviously, as I said, the hysterectomy is another question. And they often aren't prepared or even thinking that they might need a hysterectomy when they get to you, but you might want to then discuss having hysterectomy. So this is another whole new issue.
Steve,
yes.
just go back to that one. What are the Hister Sisters? What is that? Is it like a self-help website or?
Oh, Pete, you won't believe what is out there. And you know, this is why this talk I felt is relevant, because we have to embark on a whole new process of shared decision making with our patients, because they're coming with information, they are informed, but sometimes they're not appropriately informed because of the Histero sisters who will tell you that maybe she's going to have menopause if you do hysterectomy, or she might have some other sexual issues. So it's just the problem of social media and how we embrace this as we manage our patients.
So Steve,
yeah.
On the right-hand side, it says women with hysterectomies make great lovers. Is that part of Histero Sisters, or is that sort of a
I must go and look again, Pete. I haven't actually been on their website for a while, but I must go and look and see exactly what they said. But there you go. I mean, you can actually see that there's a diversity of information and opinion on the internet.
That's not part of the same website.
The disclaimer is that's just a picture I got of the internet. It doesn't. It's not
okay.
Sentiment or the Pelvic Floor Foundation sentiment or your sentiment either.
No, thank you.
Okay. So the real point of what I want to make this evening is from the study from Kim Kenton, which really just came down to patient preparedness, giving the patients information, getting them to understand the potential outcomes of this surgery, including the risks of complications. And this is from a table from that paper where they say that, you know, it's really important to talk about alternatives, the purpose of surgery, the risks. And the bottom one is important for the patient to understand that it is normal to be discharged from the hospital with a catheter. In fact, I've got two patients who are, you know, still walking around with catheters. One had a bladder injury last week. That patient still got a catheter, and another patient can't urinate after having had a TVT last week. So she's going to be back in the office tomorrow to remove that catheter. And that sort of thing needs to be on the patient's radar when they come in for their operation, because you know, if she gets that afterwards and she wasn't ready for it, it's always disappointing, and it's quite depressing when a patient comes to tell that you know, it was a bigger operation than she thought. Alternatively, that patient who you do a TVT on, the next day take out the catheter, she can wee, and she can say it's amazing. I'm one of the patients who don't need a catheter. So it's always nice to have that patient who's quite a little bit more informed, and when things go well, they're actually even more impressed with you.
Steve, typically, how long do you spend counseling women? It sounds like the list is getting longer and longer of things that you have to share with them.
I mean, I think if you're going to be seeing a patient in a one-stop setting and then, you know, bringing them straight into surgery, I like to allocate an hour. You don't always use the hour up, but you know, I think it's not a bad idea to give yourself time. If you are in a hurry and you feel like you know, need a bit more time, there's nothing wrong with bringing the patient back for another counseling session. Or you have to make sure you see them properly in the ward and, you know, walk them through it again. I don't use a lot of patient information sheets. I do have an information sheet I give to patients that's more sort of practical thing about bleeding and constipation and analgesia and that kind of walking and driving, etc. But in terms of the basic stuff, I like to talk to patients and actually write it down for them. But yeah, I mean, look, it
depends on the patient, isn't it?
You know, Pete, an extra 20 minutes of counseling might save you months of stress and dramas, you know, in a patient who's going to be prepared for it, or maybe even walk away and not have the operation, which is probably the best outcome in a patient who's potentially doesn't want to, not a good candidate for surgery. And if you spend enough time explaining stuff to them, they might actually say, oh, look, this is actually not something what I want. So yeah, that's actually what we're talking about. So yeah, when it comes down to prolapse surgery, don't forget about a pessary, and then discuss the indications, discuss the risks. I'll run through it with some pictures. You make use of this Ayuga decision aid. I've got it on my desk, and I often write. I've got an iPad and I take pictures and write on the iPad with them. It's a very visual field, remember, urogynecology. So we like to just really getting the three-dimensional aspect sorted out. You can actually see, and just showing them how laparoscopy is done. Just a quick 2 or 3 words about overactive bladder and recurrent UTIs. Remember, overactive bladder, we're starting with medication, talking them through the risks and benefits of anticholinergics, Betmega.
Sorry, Steve, what is SDM?
Shared decision making. Shared decision making.
I see.
Okay, and then you know, do you want to start a patient on anticholinergics without doing urodynamics? And then obviously talking about alternatives like a physiotherapist. We haven't spoken much about that, but that's an important part of the whole treatment regime. And you know, talking properly about physio and you know, maybe getting them to understand its role and the need and the usefulness of that. And then UTIs, you know, I see a lot of patients with recurrent UTIs. Do you embark on a prophylactic regime, or do you go and do a cystoscopy to see what's going on first? Another important part of the whole process. Do they want to start on prophylactic antibiotics or not? Not always straightforward for me. Simple things like probiotics, and you know, all those issues are often quite important. But just ending now with this little formula, really trying to keep your disappointment levels down with patients. And it's all related to the expectation that you give to patients, balanced by the reality that you actually create in their lives. And if you create too great an expectation and your reality isn't true, they're going to be more disappointed than if you lower the expectation and increase the reality. So under promising and over delivering is probably the way to go with a lot of this kind of surgery. Yeah, so I'm happy to take some more questions. I see there are some questions here, Pete.
Steve, there are.
Yeah.
The first question over here isn't really about SDM. It's a more practical question from Amir Bulyun. So slightly off the topic. With the morcellator issue in the latest data, do you do total or subtotal hysterectomy with a sacrocolpopexy?
No, how Maria, it's so nice to get that question from you. And not
and not El-Marie.
No,
Oh,
no,
yeah.
I know Almira. We saw him. We were together this last weekend in the SOGA conference. We had a nice conversation there. But great question. The morcellata issue is a significant one, but more importantly, there's always a risk in this population that there's a undiagnosed endometrial cancer. And in fact, we were doing a lot of, me and Peter Kruger, actually my previous partner, were doing a lot of subtotal hysterectomies and morcellating until we got a patient with an endometrial cancer. So then, since then, I haven't done any subtotals with the morcellator. And in fact, I don't think I'd morcellate a postmenopausal uterus. It is nice to do subtotal because you're not cutting into the vagina. You run the lower risk of the exposures due to the mesh. But I think it's a risk which is, I think, not really worth taking. And also trying to get the patient to make that decision with you is sometimes a little bit difficult because you're really balancing the risk of a undiagnosed cancer against the risk of a mesh erosion. So I'll just do a total hysterectomy and that's it.
Now,
But,
Steve,
yeah.
do you have any ethical problems with doing morcellation per se? I mean, if a woman had a fibroid, for example, would you mind morcellating up the fibroid?
No, I use a morcellate. We spoke about morcellate yesterday, please. I mean, I'd morcellate fibroids in a young patient. But yeah, I mean, there are issues, and that's probably the other thing that really is an important part of the conversation today. I think as the patient ages, your risk of an undiagnosed sarcoma does go up. And remember that this was a massive issue in the USA a few years ago, where a woman wasn't actually counseled appropriately, and they just went in and did a morcellation, and they upscaled or upstaged the whole cancer from a stage 1, I think, up into stage 4, and the patient ultimately died a few years later. So, there's a significant issue at stake here, and I don't know anyone using in-bag morcellation, but yeah, I think it's an important issue.
What's in-bag morcellation?
So there are these bags where you actually somehow get this specimen into a bag, and you blow this bag up into the abdomen, you put your scope into the bag, and you can morcellate it in this bag that then fills the cavity. So then you're not spraying any potentially malignant cells all over the inside of the abdomen.
I get the idea. Thank you, Steve. Let's see. I see there's something in the chat. Can we just see what's in the chat? Nothing important. Okay, it's about the...
That's just me.
Oh, okay.
Okay, thanks very much. Well, Steve, it's been a wonderful presentation. Just before I say a final goodbye and cheers, I'd like to thank you for the use of your mini bar. And secondly, I'd like Ruby Franken, are you still with us?
I am.
Ruby is the Group Business and Development Manager and our sponsor for this evening. And she's going to play out with a video. And then I'm going to thank everybody, and we should finish before 6 nicely. Thank you very much indeed, Steve, for a beautifully presented talk. And we look forward to more talks of this nature in the months to come.
Thank you,
Thanks.
Pete.
And thank you for allowing us to participate and sponsor.
Thank you for coming on board as a sponsor for this important topic of shared decision-making, SDM.
Thanks so much, guys.
So, Corin, can Ruby play out then with her video, the 3-minute video?
Yes, I'm going to play it for her now.
We've got
Thank
2
you.
videos from Ruby. There's a 26-minute video and a 3-minute video. And if you don't mind, we'll look at the 3-minute video, Ruby.
100%.
Ruby, thank you very much indeed. Wonderful video, and ending with a lovely shot of Sia Khaleesi. I think we all feel inspired by that video. Did you see the shot of Sia Khaleesi, Steve? We can't hear you, Steve. Sorry, can you unmute? What's that, Steve?
Sorry.
We can hear you, Steve.
Sorry.
I'd like to, Steve, if you can hear, I'd like to thank you very much indeed for that talk on shared decision-making in urogynecology, Professor Steve Jeffrey, who's the urogynecologist and co-founder of PFFSA, Pelvic Floor Foundation of South Africa. And thanks once again to Ruby, our sponsor for the evening. And we look forward next week to another talk by Clayton, the lawyer. And I wish you all a safe journey home. Take care. Thanks also to Corin for all her technical ability. Thank you muchly, and good night to everybody, and see you next week. Thank you, Steve.
Thank you. Thanks, Pete. And thanks to also to Corin. Okay. Bye.